and thank everybody for being here on this fine autumn day. The good news is we've been asking for guidance on the first topic here, the federal vaccine mandates, and I can see why it took so long, 214 pages with footnotes. Kind of reminds me of Alice's Restaurant. If you remember, my wife says you're old, no one knows you're talking about 47 color glossy photos with circles and paragraphs. Circles and arrows and paragraphs on the back of each one. That's how I felt when I read that over. So I think Ms. Rydrick has come to share some light on this and to make it all so simple for us. And then we have some testimony from others as well. So Ms. Rydrick, do you want to start, or did you want Dan to go, or Ms. King, or what do you suggest? Good morning.
Good morning, Mr. Chair. I can start, and I will note Ms. King is in transit, so hopefully she'll be able to as soon as her plane lands in about 20 minutes. But for some of the potential regulatory questions related to the mandate, it's possible that she won't have joined us yet, but hopefully. So very just good. For the record, my name is Diane Rydrick, and I'm the Acting Assistant Commissioner of the Health Systems Bureau here at MDH. And thank you for having us here again today. So as you alluded to, I have come to this committee a few times in recent weeks to tell you that I didn't have any information about the federal vaccine mandate for healthcare workers, although we were expecting that it was imminent. We didn't know when it was going to come. So the CMS rule that outlines the healthcare worker vaccination requirements was released last Thursday, November 4th. And I'm just going to give you kind of a high-level walkthrough of what's in it, and I assume that there will be a number of questions, but I'll kind of walk through the basics for you.
Yeah, high level is good.
Yeah, so the rule went into effect immediately on November 5th, and it applies to any providers that are Medicare and Medicaid certified, which includes hospitals, nursing homes, ambulatory surgical centers, community mental health centers, home health agencies, rural health, hospice, FQHCs, intermediate care facilities for individuals with intellectual disabilities, and psychiatric residential treatment centers. So when we heard about the rule earlier, it sounded as though anyone who receives any payment from a public program for Medicare or Medicaid would be subject to the mandate, but it was clearer than we thought in noting that it applies to facilities that are Medicare or Medicaid certified and are required to follow the conditions of participation for those programs, not anyone who accepts a Medicaid patient. It does not apply to facilities that are only subject to state licensure laws, such as assisted living facilities or group homes. It's very broad in terms of how it defines the staff who are subject to the vaccination requirement. It applies to all facility employees, whether or not they have patient contact, and that includes licensed practitioners, students, trainees, and volunteers, and anyone who provides care, treatment, or services at facilities under contract at a facility that is covered by the rule. It exempts people who are 100% remote and don't have any patient contact. So if you are working for a hospital in a 100% remote role and never have any patient contact, you are exempt. The rule sets up two deadlines. Within 30 days of publication or on December 5th, all staff have to have received the first dose of a series or a single dose if it's Johnson & Johnson. Within 60 days or by January 4th, they have to complete the primary series. They will be considered to have met that requirement if they've received both doses by January 4th, even if they are not yet 14 days past the second dose. It does not include an option for staff to be tested regularly as an alternative to vaccination. It does include exemptions for staff with recognized medical conditions for which vaccines are contraindicated, or for religious beliefs as established under Title VII of the Civil Rights Act of 1964. So the facilities have flexibility to establish their own processes for requesting medical or religious exemptions, but they are expected to document those requests and to follow the applicable federal laws in determining whether to grant one. Compliance will be reviewed through our existing survey process. So MDH surveyors would be expected by CMS to survey for compliance with the rule when they are out on a site doing a standard recertification survey, or if they are doing a survey in response to a complaint. And then they would be reviewing documentation and reviewing the rosters that the facility is required to establish. The rule also does lay out some penalties for facilities that aren't found to be in compliance. And they are the same penalties that exist for noncompliance with other CMS rules, and they vary a little bit based on the setting. Because not all, some settings have an option of financial penalties and some do not. But they do lay out in the rule that their goal is to get people to compliance, and they remind us that there are opportunities to address deficiencies or lack of compliance. So if a facility is found to not be in compliance, there's an opportunity for them to correct that and come into compliance before a penalty comes into effect. So that's kind of the high level overview, and I'm happy to take questions on it.
Well, yeah, that's helpful. And so, so there were at some point 3 discussions of mandates from the Biden administration, something about nursing homes, then this health facility thing, and then the employer 100-person thing. So the healthcare ones are all together now. This is the single one that has rules behind it. And if you had and so they operate independently as far as you understand. So are the 100-person, well, then there's the federal contractor thing. Mm-hmm. Is that interactive with this? I guess there's actually 4 then: federal contractor, the old nursing home thing, and then facility, and then a 100-employee deal. Is the federal contractor thing interactive with this, or does that make any sense?
Mm-hmm. Mr. Chair, it does make sense. I do think the different mandates interact. There could be situations where someone is a federal employee that's working in a facility that is required to vaccinate their staff under the CMS rule. And there could be facilities that are subject to the OSHA rule, which came out on the same day, although not the CMS rule. So an example might be an assisted living facility that's not covered under the CMS rule, but depending on their size, they might be subject to the OSHA rule. So they're
okay, and then I have many questions. I'm just limiting them to as few as I can stand, and I'll let other people ask questions. And then on the exemption part, the religious exemption in particular, so each facility will be then interpreting the federal requirements as best they can and making their own decisions on a person-by-person basis as they best judge. And then they'll be reviewed by the surveyors to see how they did, pretty much. Is that what you think?
Mr. Chair, that's correct.
All right. So, Mr. Pollack, do you want to comment about this, or should we take questions from members?
Oh, thank you, Mr. Chair. I don't have specific comments to the vaccine mandate policy, so I'm happy to take questions on it.
Okay, well, let's go to a member. There's testimony coming, but let's just to the meat of the discussion here. Any questions from members about for Ms. Rydrick or Mr. Pollack? I don't see any hands.
My hand is up.
Nelson, there you are.
Yes, thank you. Yeah. Thank you so much. Just briefly, it would be helpful to have a list of all of the impacted facilities. I listened as you read that list very quickly, but of course I cannot recall all of those, but I do know there's been a lot of questions about who is impacted and who isn't. And particularly with the new licensure requirement, we've had a number of formally settings that were independent living, but they also had a couple memory care units in that setting. But since they were under one roof, the new licensure meant that they all had to be considered assisted living, even though it's not. So I just know there's some questions. And if we could get a printed list of who is impacted, I would greatly appreciate that.
And thank you. And so for members' benefit and the public as well, there's on the website, on our Senate page, there's a copy of the entire 214-page rule, and I urge you to take that along on vacation. You're going to want to study that, maybe not. There's a 13 or so 11-page frequently asked questions, which really helps make it more succinct. And thank you for whoever wrote that. So let's go on to testimony then, unless anybody else, any member has a question. So let's hear from the care providers and leading age, and then we have a administrator who's going to testify for us. So, who's Ms. Matson, you were here to testify. Oh, whatever. So Carrie, how do you want to run this?
Oh, Mr. Chair, I believe Nicole will go first, and then if you don't mind, I would follow her.
Sounds great. Ms. Mattson, welcome to the committee.
Thank you, Mr. Chair and members of the committee. My name is Nicole Mattson from Care Providers of Minnesota, and I'm here today with the long-term care imperative. So like Assistant Commissioner Rydrick explained, the rule that was issued November 4th from CMS is a vaccine mandate for several types of facilities that are regulated under Medicare conditions of participation. And on that same day, OSHA, the Occupational Safety and Health Administration, released its vaccine requirement for employers with 100 or more employees. So the CMS interim final rule with comment period is applicable to our skilled nursing facilities and nursing facilities and other types that Assistant Commissioner Rydrick stated. Notably, it's not applicable to assisted living providers, group homes, home and community-based services, and physician offices. And the CMS rule mandates staff vaccinations with exclusions only for religious or medical exemptions. So some of this could be repetitive from what Assistant Commissioner Rydrick explained, but skilled nursing facilities must establish policies and processes to ensure that all eligible staff receive the first dose of a 2-dose COVID vaccine or 1-dose COVID vaccine by December 5th. And prior to providing any care, treatment, or other services, or that they've received and been granted a religious or medical exemption. It then requires by January 4th, 2022, that a second dose shots are received, again, with the exception of those that have been granted medical or religious exemptions. It also requires that facilities have a plan in place by December 5th for how they will handle the exemption process, how they will track and document staff vaccinations, and also how they will establish additional precautions to mitigate the spread of the virus for all staff who are unvaccinated. So that could be testing, distancing, source control. The OSHA emergency temporary standard for vaccination and testing similarly requires large employers to develop policies to ensure worker vaccinations. So it
Ms. Mattson, if I could interrupt you, could you skip forward to the part that talks about care providers and how they're going to handle this? We already kind of had that discussion. I just have a short attention span, and our time is limited to a point. But I want to hear about what you think. How are people going to do? Are they all terrified? Are they going to close? What's the impact going to be? Thank you.
Mr. Chair, I appreciate your concern. So we know that vaccination is essential to overcome the pandemic, and our members have strongly encouraged vaccination through education, counseling, public information campaigns, and incentives. But despite these efforts, many of our workers remain unvaccinated, and at present, our overall vaccination rate is close to 75% for skilled nursing, which is high compared to the rest of the country. However, this means that we have about 12,000 staff members across the state who are unvaccinated. The number of unvaccinated staff are not distributed equally across the state, and we have particular concern in those communities where overall vaccination rates are low, because that's our potential talent pool for replacement staff. We certainly hope that the mandate will encourage some who have been hesitant, but know that many remain steadfast in their declination. And we are very concerned about implications for our workforce. Ultimately, we can't afford to lose even one more worker because we're facing such extraordinary shortages. With over 23,000 openings, which is 20% of our workforce, an acceleration in turnover is potentially catastrophic for some providers. We're already experiencing 1.5 times higher rates of exits than we are hires. And 70% of senior care providers are limiting admissions because they lack sufficient staff to safely provide care to any additional residents. Increased number of staff openings will certainly lead to disruption in the availability of senior care and services and further compound the issues that we've seen in the healthcare continuum. And again, this impact could be felt more acutely in those communities with lower overall vaccination rates. We appreciate the committee's concern and renew our request to help ensure adequate staffing so we can provide long-term care service and support for all the seniors who need it. This means taking swift actions to fund permanent significant wage increases and establish strike teams to provide emergency staffing in long-term care, And I know that my colleague, Carrie Thurlow, will speak to that as well.
Thank you very much. Ms. Thurlow, welcome to the committee.
Thank you, Mr. Chair. Mr. Chair, members of the committee, thank you for the opportunity to testify today. For the record, my name is Carrie Thurlow. I'm the Senior Vice President of Advocacy at Leading Age, Minnesota. So we've known for weeks that this rule was on its way. And to some extent, we appreciate that now we have concrete information about what we are doing to move forward. But I can't be clear enough when we say this. This is a potential powder keg with a very short fuse for long-term care. We face a scenario where we don't have enough workers to serve the seniors in our settings. And despite our pleas for help over the last several months, there are no concrete solutions, either at the state or the federal levels, to help us solve our unprecedented workforce crisis. So I'm going to cut to the chase and say that there are two critical points that I would like to leave with you today. The first is that Minnesota is not prepared for the very real scenario that we may lose thousands of additional employees from nursing homes in the next several weeks as the CMS vaccine mandate takes effect. Without immediate action to implement solutions, we face devastating impacts. And I really recognize that that's strong language, but that really is, I cannot underscore how ill-prepared we are. To underscore this, I want to share with you briefly a story of a member that I've been working with this week to help illustrate this point. She might have been here to testify today, but to be honest with you, she is holding an emergency board meeting to determine whether she should begin planning for a process to transfer residents and close her facility due to staffing shortages. This is a small 45-bed city-owned nursing home. They've not been accepting admissions for months now due to low staffing, and they're down to 25 residents. They employ 104 employees, so even the loss of one employee takes its toll. In August, when the announcement came that there would be vaccine mandates in nursing homes, she lost 13 staff immediately. Since then, they've had very few hires, even though they've deployed all of the best practices, and we can talk about that. And now that the CMS vaccine mandate has gone into effect, employees in that setting that are not vaccinated will be leaving. Most will stay until December 4th because they really love the work that they do. And as of December 4th, they expect to lose 21 more employees. That includes, these are essential, 3 registered nurses, 10 CNAs, a staffing coordinator, 2 housekeeping aides, a cook, an activities director, and 4 dietary aides. She asked for help, and we as a state do not have emergency solutions at the ready for her, and we are weeks away from this becoming a reality. But this provider is not alone. As Ms. Madsen stated, the unvaccinated individuals in our state are not evenly distributed. We know, for example, today that there are about 13 nursing homes that have 50% or less of their staff vaccinated. The provider I just described has a 77% vaccination rate, which by most standards is good. Our benchmark for success in the general population is a 75% vaccination rate. But even at these levels of vaccination, she's at a staffing crisis. So the second point I want to leave you with is that the next 30 days are critical, in case you haven't taken that away yet so far. I can't urge you enough to work with us to ensure that our key focus has to be to retain as many current staff as possible and to make in nursing homes and to make coordinated contingency plans to ensure that seniors continue to have access to quality senior care options. While it's very hard to predict how many unvaccinated employees in our settings will become vaccinated and stay, or obtain a medical exemption or a religious exemption, we know that most settings cannot even afford to lose 1 or 2 staff members at this time. For many nursing homes, this will not be a sustainable loss after staffing losses that we've endured over the summer. So there are a couple of action steps that I'll just briefly touch on. First, we're asking to use American Rescue Plan money to provide immediate, significant, and permanent wage increases for nursing home staff. We know that we are far behind market rates compared to the rapid wage inflation that is occurring. And this, along with the softer mandates on other businesses subject to the OSHA rule, will place nursing homes at a further disadvantage. Help us offer wages that retain dedicated staff in our settings and potentially recruit other vaccinated individuals looking for work. The second piece is help us develop emergency staffing solutions that are specific to long-term care to address scenarios where providers are suddenly left without staff to continue to meet the needs for the residents in their settings. And finally, help us reverse the DHS decision that will take effect that offsets federal funds received by nursing homes with reimbursement rates. I know we have a provider here to talk about this issue specifically, but this policy is further harming our ability to recruit and retain staff and to set predictable budgets going into the next year. We've always appreciated the Senate's focus on senior care issues and the bipartisan support of the legislative body in ensuring that seniors have access to care in their communities. I appreciate your concern, your attention to these issues, and we look forward to working with you to address these important concerns. Thank you.
Well, thank you. That is, I appreciate your candor, and we'll come back to. I think eventually the departments should be prepared to handle how are they going to. The questions are going to be how are you going to handle life on December 5th? It seems as though it's really a 30-day mandate since the first shot has to be in arms or there's an exemption. Well, I guess, and then we have a testifier, but let's just, you've kind of set the stage a little bit, so we're going to come back to the testifier later. Senator Utke and then Senator Benson.
Thank you, Mr. Chair. And just a couple quick comments for the last couple testifiers. My question there is too, what are you doing to push back? I mean, in my mind, these are all unconstitutional mandates that we're talking about. And that means us at the state and every organization needs to push back because we are losing the providers, whether it's our nursing homes, our medical providers. You know, it was mentioned that we had 23,000 openings, and that number is growing. To me, more money, yes, better wages are always good, but who's going to fill those spots? We already have such a shortage. There's nobody there to actually probably accept the offer. So I think we as a whole, everybody included, need to, I mean, we've got the immediate need at hand, but we also have to push back because this has gotten way too far. The nursing home that was just you just talked about, I think many of us got this letter from that particular nursing home. That one is serious, but we all live in small communities that are experiencing the same thing. Our nursing homes are on the verge of closing, and that's somebody's loved ones, and we all have had loved ones in those facilities. But I think we just need that plan, and we all need to be on the same page for pushback rather than just accept what the federal government is pushing towards us. We need to stand up for ourselves too. Thank you, Mr. Chair.
Did you want to reply, or is that, it's a really good comment. Do you want Ms. Thurlow to comment?
Mr. Chair, members of the committee, Senator Utke, I would just briefly say that, we have continued to urge, since vaccine mandates were first being discussed this summer, we have continued to certainly support the idea of supporting individuals that are getting vaccinations, but also recognize that there are sincerely held beliefs for individuals who are not receiving vaccinations. And we have continued to sound the alarm that this will have an impact on our workforce. We had hoped that there would be a similar approach to what is reflected in the OSHA mandate, more of a softer approach that provided a testing option. That was unfortunately not included in the CMS mandate. So we will be commenting. I believe both organizations, Nicole, I don't want to speak for you, but I believe both organizations, along with our national organizations, will be commenting during the comment period of these rules.
Okay. Mr. Chair, if I could just one comment. Okay, thank you, Mr. Chair. And again, I think we need to be, it isn't just a gentle push. We need to get a solid push put together to go back at the federal government. This thing about possible testing, and that's being a soft way. You know, I had a state trooper come to me a week ago and said, you know, they're going to make us spit in a tube now and send in our, and they referred to it because they deal with it a lot, sending in my DNA to be tested. And they said, you know what, if I go out on the whatever type of a call that state trooper would be on, and if they got to take your DNA, they have to go and get a warrant signed, and they have to go through all the proper procedures. But yet we're expecting people to just spit in that tube and send it in to be tested. This isn't just a small little thing to a lot of people. So, and then we've got those that already have the immunities, and yet they've got immunities that are much better than anything that this vaccine is supposed to cure or protect them, according to what we read and hear. But we don't take into account any of those things. So I think we need to bring an all of the above approach to this. And because, I mean, again, this is a serious issue, maintaining our providers, whether it's nursing home, medical clinics, hospitals, etc. So let's go at it with a bold approach.
Thank you. Senator Benson.
Mr. Chair, I just noted that when we're talking about receivership, there's all kinds of flexibilities given. And perhaps before putting a nursing home into receivership, we should listen to these providers and actually give them some of that flexibility prior to shutting them down and putting MDH in charge of the nursing homes, or putting an agent in charge of that facility. It's been my experience on private phone calls and public hearings that they are reticent to do any sort of administrative flexibility or wage flexibility until after receivership happens. And I don't think MDH or DHS have a plan for the level of receivership that we might be seeing with the loss of staffing.
Thank you very much. Let's go back to our testifiers. Ms. Lesnikar, we've queued up quite a conversation. If you could do me a favor and say anything different than what everybody else has said, but in the context of your world, we had some really good conversations offline for 2 or 3 minutes, and then we'll keep discussing this. So welcome to the committee.
I'm just saddened. I've been in this field since 1983 as an aide. I'm a nursing home administrator.
Well, tell us who you are. So do your name.
I'm Natalie Lesnikar. And I have built assisted livings. I've ran them. I run them for somebody else now. And it is the saddest day I've seen. I don't care what party anybody is at this point. I care that we're Minnesotans. I feel that the road to hell was paved with good intentions. We all know that saying. Brings me back to 1991 when I started as a nursing home administrator. And at that point, we tied every resident down. We syringe fed every resident because they didn't eat. And I was told as a nursing home administrator that we're doing good. You know, we're helping people and we're doing what's right for them. We're taking care of them. We're saving them from falling and hurting themselves. So what happened? In every nursing home, you heard people hollering, help me, help, 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 help. Nobody wanted to live in a nursing home. They wanted to be released, and we told them we knew what was best for them. Who's we? Who knew what was best? We was the nurses, the doctors, and the state of Minnesota and the federal government that told all of us as providers we knew what was best. And we followed the rule. And then pretty soon family members started to push back. And the state and the federal government started to listen to the residents and the families. And guess what happened? We released them. And we released them, and we didn't change Alzheimer's, Parkinson's, congestive heart failure. We didn't change a disease. We changed the lens that we look through it. So now who's hollering, help me? I hear now, after being in this field for 40 years, who's hollering, help me across the state? It's a new population. It's our employees, the very damn people that have taken care of people like me, working as an aide, as a CEO, twice through COVID. And I'm not doing it anymore. I'm going to be the next one that leaves the field. I'm 55. I've had 8 surgeries for breast cancer. I have half a muscle. I'm doing above and beyond every day. And I get calls every day from colleagues, you know, I'm 55, I have other options. I'm fighting for everybody that doesn't. I'm fighting for the aides, for the housekeepers, for the maintenance people, for the dietary, for small town Minnesota, for Metro. I hear it across the state. Why are we labeling and judging everybody? Does anybody realize that we're not going to have anyone? We have 18 months of COVID. I've been doing statistics for 18 months. We've got less than 0.5% of the people have died in the state of Minnesota. Less than 0.5%. I do statistics. It's math off of the state of Minnesota's website. I'm done with hearing about science. People have been hearing about science. It's becoming political science. I'm going with math. I look at the numbers, and in every country and in every state, regardless of political party, it's the same damn outcome. We're at about 0.5%, 2% of deaths we've had worldwide from COVID. That's not polio, and it's not the other diseases. So you wonder why people are worried and wondering, and they're hesitant. They're saying, look, let me make a decision for my health and for my family. I'm not going to ask questions on what they had. How are we going to figure out how to determine this religious exemption? You know, who's going to decide? All the people that said they had to get vaccinated for the hospitals where nurses have quit, doctors have quit. There's a doctor from International Falls, I believe, or Thief River Falls that got fired for not taking the vaccine. There's many of them. I've seen them, heard them, talked to them. So what happens now? We got a new mandate from CMS. Do they get to have a religious exemption or a medical exemption and get brought back? Or are they just gone? Do the providers just get to have them gone? Because now that the hospitals are short, we got travel nurses making $7,800 a week to go across the country to be a travel RN. How am I going to find an RN in Babbitt, Minnesota? How am I going to find a CNA in Aurora, Minnesota, Burnsville, Minnesota, as an assisted living? We don't have Medicare money. We only get private pay and medical assistance, and medical assistance pays nothing. So the wages are just going sky high in the hospitals and the nursing homes for an aide, $20 for an aide, $30 for an LPN, $40 for an RN minimum. And if you're a travel nurse, $7,800. I know people. I've never known in 40 years anybody that left to be a travel nurse. Now they're selling their houses and they're going. Why not? They can homeschool their kids. They can do virtual learning. They have a lot of other choices and they're doing it. So we all are struggling now from what we've created because we're being rigid. I think history is going to show that we're making a mistake, that we're not, we're creating a greater harm for people we say we're protecting. I feel like it's a tragedy for Minnesota. We're going to be sitting here with a lot of facilities. Assisted livings are going to close. I get called every week asking if I'll take a job. I'm one person in this industry. People don't want to be in it. If nobody wants to be in it as a CEO, as a nursing home administrator, as a campus administrator for a hospital, that's at the highest level. Imagine being an aide, the housekeeper, the dietary aide. There's nobody for the jobs. We're not Dairy Queen. We can laugh when we say, oh, you're only going to get drive-through today because we don't have enough staff to cook. Well, it's a soft serve cone. I'm taking care of people 24 hours a day. This is not drive-through. We need people. So the state of Minnesota has got to take a hard look. If they force this hard, history, I think, is going to write itself its own story. And it's pretty clear to me that we're losing good people. I'll be one of them because I can't put my health in this situation. And that's what I hear across the state. People can't do it anymore. So it's a funding issue. It's a reversing policy issue. It's a tolerance issue. We have created the mess we're in.
Thank you very much. That was, I wish you hadn't been so eloquent. And I don't even know how to disagree with one word you said. So I don't know. Mr. Pollack, we're going to put you on the hot seat first, and then we're going to talk to Ms. Rydrick. It came up suddenly, but we all saw it coming. We were nervous about it. We've talked about one or two receiverships that are out there. Senator Benson talked about flexibility. And the leading age says we're ill-prepared to handle the crisis that's ahead of us. Mr. Pollack, what is our emergency plan for this when it happens in literally 3 weeks?
Thank you, Mr. Chair. Dan Pollock, Assistant Commissioner for Older Adults at DHS. I first want to disagree with something you said at the beginning of the hearing, which is it's too bad we're having so many hearings. I actually think it's good that you're having this many hearings. I'd like to have more conversations with you and the members of the committee. Generally, as a statement, I think we agree that the lowered bed capacity and the need for staff is an absolutely urgent priority. So we are, all of my team has been working pretty much 7 days a week to sustain nursing facilities and think of ideas for helping them meet the critical needs of their residents. We want to see nursing facilities remain open. We want to see them continue the important care delivery work. The post-acute system is a vital part of the care system. And we care about these providers and the workers and the residents. I can't guarantee an outcome, but I can promise an extraordinary effort is being made right now. And I'm committed to meeting with you today, tomorrow, this weekend, whatever we need to do. I know from personal experience and talking to these facilities that the efforts on replacement staff are expensive, are frustrating, are frightening. There's a couple things that I do want to just flag. CMS made $25 billion available in October. I know many of them applied for that. It's about $200 million just for Minnesota. We need that money to come to nursing homes as fast as possible to help with the cash flow. And as far as DHS is concerned, we're open to using additional state or federal funds. We just think that that needs to be a bipartisan, bicameral solution. Let's work with the technical assistance. Let's operationalize the emergency responses that the House and Senate and Governor can all agree are needed right now. So, happy to delve into more with you, Mr. Chair, anytime.
Well, thank you, and I appreciate that. I don't just as a person, we just spent a lot of money just lately. We had 1.3 billion in one-time money. Never had that kind of money in our time. I don't know what kind of money is going to fix this. It's a body thing and it's a requirement. And the Biden administration, this is not a political statement, but the administration decided that this was going to be something that they wanted to do, and they ran an emergency rule through requiring the action by people like Ms. Zeleznikar that they knew were not going to comply. They knew that she was not going to do this, or the likes of her. And I totally respect her freedom to decide based upon her own health situation what medical treatment she would avail herself of. We're not debating that today, but anyway, so I'm just, it's a human body problem. There's even in more pleasant work, requiring a lower level of dedication. There's a Starbucks our area that closes at 1. People still want coffee at 2, but they can't find the people. So, and that's not a function of even the vaccine thing. So anyway, thank you. I think you said it as well as you could, given your parameters. I know how well intended DHS is, and even MDH too. So, Ms. Rydrick, did you want to comment on? I'd like you just to react to the statement, if you can, by Ms. Thurlow, that Minnesota is ill prepared to lose thousands of workers and handle the emergency. Can you tell me what plan you're going to put forward, please? I'm trying to ask it nicely. It's a really hard question. So please, welcome to the hot seat.
Yeah, Mr. Chair, I think Ms. Thurlow is correct that this is a really serious issue for this industry as a whole, especially for skilled nursing facilities, because they were already struggling with staffing shortages. Ensuring that our seniors, our family members, have a place to receive care close to their loved ones is critically important. So I agree that we have the same concern that some facilities may not be able to get through this. And I agree with Assistant Commissioner Pollock that we need to look at all facets of the solution here, whether that is additional funding to increase wages, whether that is, other types of state or federal financial support that might need to be available to facilities, whether that's looking at options for facilities to, partner with another facility to, co-locate their residents and, figure out a way to make use of the staff they have and avoid closure. I think we have to look at all those options. We've been talking with the regional healthcare coalitions. We've been talking with the hospitals about how we're going to make sure that residents can be safe if we do end up with some facilities that are on a path to closure, and we will continue that work. We care deeply about this industry and the residents who they care for, and the staff who have been on the front lines for the last 20 months. It's been an incredibly difficult time for them. And, you know, I echo what Ms. Thurlow said. We have had administrators and directors of nursing on the phone with us in tears because they, as you put it, Mr. Chair, they can't find the people. It's a body issue, it's a money issue, it's an existential issue in some ways for this industry. And I think we all have a really some hard work to do in the coming months to get all those options on the table.
Senator Abler, can I ask a question?
No, please. Well, no, you have to wait to be called on. So just, I've got two members ahead of you and I'll come back to you. So, okay. Sorry. Senator Benson and then Senator Hoffman, and I'll let you ask your question. Okay. Senator
Thank
Benson.
you, Mr. Chair, and to Ms. Redrick and Mr. Pollack. I had a meeting a month ago, probably about a month ago, to ask what the plan was. And I would like to know what concrete steps have been taken in the last month to relieve some of the pressure. Are we pushing back on the Biden administration in any way, shape, manner, or form? Have you developed a funding proposal and requested a special session? What concrete steps have been taken? I suggested combining facilities where that is possible to make staffing more efficient. Are we down the path on that at all? Is there any accommodation for lifting the cap on hiring nursing staff? Because right now it's capped, and I do not have clarity that the legislature said it, or was it done by rule, or is it just guidance that could be adjusted through DHS? So I would like to know what specific actions have you taken in the last month to alleviate the staffing shortage? Because the things you talked about and saying it will take months is not going to work. And we have 22 National Guard stood up at a decompression site to take pressure off the hospitals. Now it sounds like the solution is, well, if a nursing home shuts down, we're going to send them back to the hospital. That's makes zero sense. To have the plan be, let's send them back to the hospital. So in the last month, what specific things have been done to relieve the pressure on staffing, either by lifting the cap, allowing for combining accommodations, pushing back on the Biden administration? Tell me what specific things were done, because it's been a month.
Did you want Ms. Rydrick or Mr. Pollack? Who did you want to answer your question?
I will take either, because they were both in the meeting.
Okay, well, Ms. Rydrick, then Mr. Pollack.
Thank you, Mr. Chair and Senator Benson. And a couple of those questions I will actually defer to Assistant Commissioner Pollack, because he can speak to the timeline and the process for raising the cap on skilled nurse, supplemental nursing the charges and the timeline for that to happen. And we can also both, I think, speak a little bit to that idea that you raised, which I think is a good one, which is thinking through how to let facilities potentially co-locate their residents with another organization if that's the right path for them. And those are issues that we have been moving forward with DHS on, and can certainly, I think Dan would be able to share a little bit more of the progress on that. At MDH, we have also been looking at the best, quickest way to use federal funds that we have in hand through a new CDC grant to expand what we can do for emergency staffing support for facilities. We have some crisis staffing support that we're able to provide to facilities that are having an outbreak. And we are looking at how we can expand that, allow that resource to be used to also find staff who are, dietary, housekeeping, other non-direct care staff in facilities, and how we can get more people into that pool. And we're looking at how we can remove barriers to CNA training to get more people into the pool in the short term and in the longer run. So to Assistant Commissioner Pollack's point, looking at how we can use all the state and federal resources that are available to us, I do think we have some opportunities with federal funds that we have or will have in hand very shortly. But I will ask Assistant Commissioner Pollack if he can say a little bit about the SNSA max charges and about some of the options around potentially co-locating residents, which I think is, for some facilities, one possible route to prevent closure.
And Mr. Pollock, and I remember actually working to pass the law to handle out of control nursing pool rates, probably with Representative Bradley back in the day. Anyways, Mr. Pollock, go ahead.
Okay, thanks, Mr. Chair. Yes, section 144A.74 very well could have been authored by you. That will allow us to publish new maximum rate charges for the upcoming calendar year in December 2021. To Senator Benson's questions, all of those things have been looked at and discussed, and there are just limited things that we can't, that we are able to do without legislative action, without bipartisan, bicameral agreement. But like I said in my remarks, I'm happy to look at any ideas. I think there's a proposal in front of the committee today that is very interesting. Certainly, we've reached out to CMS again, just as recently as yesterday, about the status of federal funds and how those should be treated and how they interact with Medicaid. It's very difficult for a state like Minnesota, where we are a cost-based system, and statute says that we have to recognize both costs and revenue. So all of the things that you identified are things that we're interested in talking more about. As to Assistant Commissioner Rydrick's question, or your question about combining facilities, I don't actually have an answer on that one today. I guess I would really defer to the providers about what that would look like, or if that's something they're even really interested in pursuing.
Mr. Chair, follow up. So, Mr. Pollock, I raised that a month ago, and it was based on a real scenario from a director of nursing. So a month, and you're saying, oh, the facilities that are already understaffed and are getting tags for not having enough staff and not doing the right kind of care, they're supposed to come to you with a solution. So if you need a legislative solution, send language. We have not seen language. Please send it so we can look at it, vet it with stakeholders. Obviously, the governor would need to call an emergency special session. But when we start seeing nursing homes come down and go into receivership, this is going to be an emergency. So if you have legislative needs, send us the language. It is, honest to God, it has been a month, more than a month, since you and I and Ms. Redrick and Ms. Thurlow had a meeting about what the plan was going to be. And I am ready to look at language from MDH and DHS that they need to get the flexibility necessary before people go into receivership and seniors end up in hospitals.
Thank you. Senator Hoffman.
Thank you, Mr. Chair. And I'm grateful for this conversation this morning, because it also brings into light, there's a spotlight too in the PCA world. And as long as Mr. Pollock, Commissioner Pollock, is giving his services to have another meeting, no, I'm being serious, Dan. I really think you have we do have another problem there too, where the reimbursement rate is at like $4.90 per unit. And when you add everything up, you're competing against Quick Trip or Kentucky Fried Chicken that are starting people at $18 to $21 an hour. And it's like, how do we access, how we can get access to that, COVID dollars that's still sitting there? What are some of those solutions? I want to be part of that conversation, Senator Abler, with you and Commissioner Pollock, if that's a possibility, because I think that the system itself, caring for individuals, is in a big hurt, and I'm hearing that today. And I'd like to get something. I'd like to get something done even before we get the session started in January, if that's appropriate.
Ms. Zalesnikar, just briefly, what did you, what were you going to react to? And then Senator Whitman.
I guess my concern is right now, 70% of the nursing homes are not taking admissions because of staffing. So that is a concern for assisted living. I oversee assisted living, and as a state, we built many assisted livings and wanted that. We delicensed nursing home beds. I'm a nursing home administrator. It's how long I've been doing this. So now it's not going to be that they're going to be sent to the hospital, because the hospital sends them back to us. So when we have residents in our assisted living that need a higher level of care, because we have a continued stay criteria that the state asked us to do, and we can't provide the care. We don't do two-person transfers. We have no place to transfer them to. So they send them back from the hospital to us, and we're responsible to take care of them, fully knowing we don't have the ability to do it. And in a world prior to today, we would have discharged them to a nursing home. So the assisted living secondarily get very little funding for medical assistance. 50% of our buildings are medical assistance. So we have no ability to increase our wages. So if we just talk nursing homes, the assisted living world is going to crash because we have a medical assistance population being served in rural and metro. Third, I think we have to all acknowledge that we have, the staff tell me, and I go across 14 towns, northern Minnesota, from Silver Bay, Ely, all the way to Metro. And what I hear is we've created a hostile work environment. The state and federal government has spent 20 years on not having bullying and a hostile work environment. And the employees are leaving in groves because they feel like they didn't get hero pay when we all were there working for 18 months in a pandemic. And now they are being targeted and they are being a line in the sand, and they feel like it's the most hostile environment, and a culture matters in these assisted livings and nursing homes. It's not just pay. If you think it's just pay, you need to spend a day in assisted living or a nursing home, and you'll find out it has nothing to do with just that.
That's very helpful. And I think that I see this as a productive discussion, and I think that there's some good players in the conversation here. And I think but this is really hard. Senator Wickland, can you solve this for us?
No, probably not. But I guess my question would be for Ms. Thurlow, or well, I think it's for Ms. Thurlow. I guess, what role does the care industry providers organization play in terms of facilitating, understanding where needs are critical and how we can solve them in particular cases? I mean, it sounds like the discussion about co-location or, that type of thing. We need some way to facilitate people knowing where these particular situations are. And I guess what role do the industry or the providers play in terms of facilitating gathering the data to understand where the most critical needs are and how we can avoid or how we can address their particular situations?
Yeah, Ms. Thurlow.
Mr. Chair, Senator Wickland, very briefly. So we are working very closely as liaisons between our members and the state agencies when our members contact us and they are in crisis. The example that I provided, our member came to us to try to find inroads into with the right connections after she had tried mightily herself to try to find solutions to address her staffing needs. So we work one-on-one. Both associations, as the long-term care imperative, do collect data from our members to try to gauge where we are at with regard to the workforce situation. The data that Ms. Madsen shared with regard to 23,000 openings that we have today, we collected in September. We updated that survey a month later and showed no improvement in the situation. So we collect aggregate data as well. But I'm going to be really candid just for a moment that, and we are happy to participate in any conversation around solutions. We meet with MDH and DHS almost daily to talk about and brainstorm solutions. But if we are stuck trying to brainstorm solutions on a case-by-case basis over the next 30 days, that is going to be hugely problematic. I think we need to have better, clearer channels of options and clear protocols to make sure that as providers come into crisis, that we have a very clear plan here. And I think that we are very sorely ill prepared for that.
Senator Wickland.
Yeah, thank you, Mr. Chair. I guess it seems to me then that we need to identify a way to, create the space for that to happen in the short term, along with solutions that are addressing wages, or, you know, in a broader sense, what do the wages need to be to help change this situation? I mean, I think, Ms. Thurlow, you indicated that needed to be part of the discussion, but we would have to understand exactly what is it going to take to really address wages in a way that can broadly help the situation. So it sounds like there's tactical needs in the short term of trying to address particular organizations and what staffing, you know, where they're at, and that along with sort of a broader across the state solutions. And I'm just not clear. I guess it's not clear to me who is going to take that tactical work on in a way that's, you know, kind of systematic and getting at solutions for individual situations. I'm not sure if that's something that MDH or DHS has the capacity to do, or feels that they would be in the right role to do that. And I'm also not hearing that Ms. Thurlow indicating that they feel like they're in the position to be able to do that. So how do we go about building capacity to take those actions? And I guess I'm not sure if that's a question for
Ms. Mattson, you want to take a crack at that for a minute or so?
Mr. Chair and Senator Wickland, if I could just add something to what Ms. Thurlow said. We have created, along with the Minnesota Department of Health, a crisis self-assessment so that we could kind of get some data geographically about the state as far as who is in levels of crisis, and trying to monitor that data over time to look at changes. And part of that is the implication of vaccination, but also just implications of overall staffing crises. So just on the finding who is at risk, we know that there was about 26 facilities that were already at risk, and that was maybe over 3 weeks ago of closure. So finding out who those people are, I think we do have a fairly good idea, but I would echo Ms. Thurlow's sentiments about actual, real tactical solutions that we need to intervene right away with those facilities are very much needed.
Thank you. Well, this is, it looks like everybody who's wanted to comment has commented. I'll just offer my final thoughts here, and they're a little substantial. I believe the answer to this falls upon everybody on this, in this meeting. The people who didn't get to talk, who are watching at home, who are hoping something can happen, the departmental players, the legislature. If you just threw in the House, you'd have the whole mix. And the only people to figure this out is us. And I just want to say this in the most gentle way possible. We had a system that was at risk in the beginning. COVID rattled the whole long-term care industry, and they were withstanding it. The thing that changed everything was 214 pages of rules that said a third of the employees there can't work anymore. And on the same federal level, in a way to make them feel better about it, that 1/3 who were reticent to want to take advantage of the situation, comes an OSHA rule that says, by the way, employers, we don't want to know if anything bad happens to your employees because we don't want to disrupt the vaccination program. If you want to have a perfect storm, it has been created, and it's not been created by Minnesota. It's been created by the feds. And I'm not going to question their motives or their good intention, but the effect is it is going to collapse Minnesota's long-term care industry. And I think that I don't think we've been clear enough. I mean, hopefully the outside world is watching this as well. And welcome to our world if you've been watching, and to the press and to the citizens who are watching. But we are 3 weeks from the virtual undoing of Minnesota's vaunted secure long-term care system for our seniors, and people and without capacity to fall back on. It's a big deal, and I wasn't sure when I'm going to meet next. I guess we'll come back maybe on the 8th, which is a Wednesday, we can see how things are going. I did not call this hearing to just say who's the one biggest at fault, but I'm here to tell the Department of Health, we're here as a partner. Department of Human Services, we're here as a partner. House, we're here as a partner. Senate Republican, House members of the Senate, Democrat, Republican, I didn't say it right. There is no partisan benefit in this thing going back. Only thing that's going to happen is people are going to come to harm. And so my short-term advice is to the governor, would you please call up Mr. President Biden and say, suspend the rule. We are going to put 1/3 of the people out of work in some of these greater Minnesota places and create our own bed. And I don't think we can withstand that. And sometimes it's time to put a pause, put in the clutch, and just wait a bit. And let's stabilize the industry in other ways. And if it's a good idea come May, then maybe that's the time to proceed, some distance time. But if you haven't been paying attention, December 4th is a big day. Because at that point, every person who's not gotten their first vaccination, who's not about to get one, is out of compliance. And that building, that provider is subject to deficiencies and fines. So anyway, I don't know, anybody else want to say anything at the end of this? We have other things to talk about that are related, but I think this is a really productive discussion. And so I don't think there's just smoke, I think there's fire. And the people on this call really are the folks who are in charge of doing it. I think the answer is all of us. And I'm here to be a part of that. So anyway, I didn't think it'd be that dramatic of a segment, but I think it's important. And so I don't know if we'll get through all the rest of the items that are all important, but thank you for people's attention to this. And I hope you sense here a bipartisan, administrative, legislative concern, compassion, resolve here. And we've got to stick with that. Anyway, so let's move to the next item. And so, Ms. Rydrick, I don't really need very much of we're just curious, how is that going? I just want, especially given the time, just how is that going and what's the next plan for the next rollout of some more of those guardsmen, persons, whatever. Ms. Rydrick, are you there?
I am here. Yes. Thank you, Mr. Chair. So on the decompression activity, so just, I won't go into the history of it and the goals because I do think this committee probably is familiar, but I can go back into that if you need.
We talked about it before.
Yeah. So, I mean, we're working to, it's going well. So we are making really good progress on this initiative. You had heard last week that we opened the in Shakopee. The second site is in central Minnesota and it is opening today. Those first two sites together are adding 64 beds, which will then be newly available to allow admissions from hospitals and increase the flow of patients from hospitals to post-acute care. We're also working with those facilities to make sure that there are good plans to assist people who are ready to move home or back to a community setting outside of the nursing home when they're ready. And we are working on finalizing the plans for a third site in the coming days. There's two things I want to call out. One is that, well, maybe three. We're really appreciative of the facilities who stepped up to play this role. In the last few weeks, we have talked to a lot of candidate nursing facilities who really want to step up and play this role. They want to be able to take TCU patients again. They want to be able to support the hospitals that they're used to working with. And they have been really fantastic in stepping up to do this. And I want to call out the National Guard. They've been phenomenal partners throughout the response, throughout the pandemic. They have been willing and able and flexible to do whatever they are asked to do, and we are incredibly appreciative of them. And just finally, we are receiving some additional federal support for this, thanks to the governor reaching out to the White House and letting them know that we need some federal support. And so the second site that's opening today has a team of federal nurses from the U.S. Public Health Service who are helping to staff it, and they will be supporting the third site as well. So we're really appreciative that the governor reached out to the federal government for help and got us an additional team of federal nurses to support this work. So we're feeling really, really positive about how it's been progressing over the last week.
Senator Benson. Senator Benson, was your hand up? Did you want to ask something?
Yes, Mr. Chair, and I
Oh,
forgot to
go ahead.
unmute myself. Thank you, Ms. Rydrick, and yes, the National Guard stepping up has been terrific, and the nurses coming in from the feds is very helpful. It's my understanding that these decompression sites have kind of a veil between regular nursing home operation and the decompression site, and so staff can't be managed across purposes. The staff that's in the decompression site can only work on the decompression designated areas. Is that a correct understanding?
Ms. Rydrick?
Mr. Chair and Senator Benson, not quite. It depends on the staff. We do have staff from our private vendors who are working to support the first site as well. And in some cases, they are supporting the facility kind of elsewhere, depending on the needs of an individual patient. Sometimes they might need to have a facility staff person care for that individual and then have one of the temp staff provide support elsewhere in the facility. So there is a little bit of flexibility there.
Okay, because it's my understanding that, thank you, Mr. Chair, that nursing home staff still has to do the assessment and all of the paperwork that comes with these decompression sites. With the decompression sites, does it have to be site specific, or could you, for example, divert 3 RNs to an existing facility so they could take another 30 patients from a hospital? Or does it have to be in the model as currently constructed?
Ms. Rydrick?
Mr. Chair and Senator Benson, we're actually having some conversations about exactly that with the hospitals. That came up in the C4, the Critical Care Coordination Committee. We know that there are some health systems that had in the past set up their own decompression sites, and they're interested in talking about different models of doing that. And I believe we're talking with them tomorrow to see whether there's any way that we could support that. But, you know, we are selecting these decompression sites and doing our due diligence to find them. But if there are other ways that we can provide that support and work with the health system, we'll do our best to make.
And I think, Mr. Chair, I apologize, Ms. Rydrick, if there's a way we can, instead of being site specific, provide support to facilities and say, okay, you're a designated decompression site. And so if you take this staff, tell us how many hospital patients you could take as a decompression site before you open up to other public entrance sort of patient. Mm-hmm. So I want to make sure that we are looking at this federal resource as flexibly as allowed to optimize, because if we can get 3 RNs to get 30 patients out of a hospital, as opposed to the 22 National Guard troops that are getting 60 out, we might be better off supporting facilities that way.
Ms. Rydrick, anyway, so I have go ahead, Ms. Rydrick.
No, I was just going to say, I appreciate the comments, Senator Benson, and we are having those conversations. We want to be open to the best, most efficient ways to make this work. So I appreciate that.
And let me just offer a word of encouragement to both departments. The quality of care issues have been very important to me. The abuses of the past where people would not do what they said they were doing and all that. I have helped make our management as stringent as anybody else. And I'm happy about that. But now as we look into a time here where there's gonna be a time of crisis, where you're maybe not even gonna have the place stay open. I just heard you say something about, maybe we can allow that, or it's not exactly what you said, but it's like, you know, we're open to that. I think at this point, as we move into the next 3 weeks, where we're talking about emergency staffing solutions and so on, I think it's time to triage the kinds of infractions you'll be seeing. Some are petty and they violate some rule somewhere, but they just don't matter. There are some that are significant, but they don't result like it's a staffing ratio that's a little off, or some formula that just didn't line up. That truly is a violation, and it's not nothing, but it's inconsequential in terms of patient care. And then there are things that are really going to affect the safety and quality of care for the individuals. I think if there's a way to somehow blind, not that's the wrong term, but just quit even noticing those little first and second level things and really deal with what's important to get us through this time. I'm not confident that the governor is going to ask Mr. Biden to stop for a while. I hope he does. But if he doesn't, we're going to be sitting in this just really big amount of troubles. And so part of that is regulatory flexibility. And I, among others, I think would stand up and defend you in that. So anyway, anybody else want to know about National Guard? Alrighty. Let's move on to the nursing home thing. The care provider, the imperative has brought forward some ideas that they're concerned about. Some are, we talked about emergency staffing solutions, which I think is going to be in front of us for the next 4 months at least or more, growing to a crescendo and living on a hellish plateau. But there's one thing I thought that we could do that made sense, that was we could get agreement on money. I was informed that because of perhaps statute that the state was required to recognize the payroll protection money as a revenue stream, not as a separate pot of money. And then they had to adjust the rates downward because of that for 2022. The department has some comments. I don't know if the testifiers can be brief about this when they get to it, but and I think Mr. Pollack has a presentation. But I'm proposing that we do a one-time $100 million state-only grant to address this, if even as a way just to start the discussion. But that's my proposal. It's not from my caucus. It's not from anybody but me. But I'm afraid that I think everybody, and I do have some people that think it's a good idea of asked behind the scenes. I won't market their names, but I think everybody thought that payroll protection was kind of this unique pot of money. Here it is, go stay open, get through this, weather the storm. I don't think anybody thought that, we talked about making it tax exempt, and now but there was no discussion about we're going to take it away. So anyway, with that, Mr. Pollack, maybe I've made it easier or harder to describe this, but welcome to the committee again.
Okay, thanks, Mr. Chair. I'll be really brief, and also Director Val Cook is here from my staff, just if you want to spend more time on the technical details. As you articulated well, Section 256R.02 and .10 are both state law requirements about how we treat public grants. That's an important phrase. And the question is whether the PPP loan, the Paycheck Protection Program, which is a federal program that went to some nursing homes, but not all of them, and some small businesses, but not all of them, when those loans were forgiven, was that a public grant for purposes of state law? It's an important CMS question, and I really appreciate your creativity on it. I think you're coming up with something really good, and we just need to maybe have some more conversations about it, both with you and CMS, because I think just as this committee has touched on before, fiscal management and federal compliance are really important details, and we cannot kind of just let those go. So that's just mostly my comments. I really do want to talk more about it, and Ms. Cook is here if we want to delve into the statutory.
Pollack, thank you. And so you're quite persuaded. You don't see it as an overly strict interpretation of the reading of the statute that there's no way out of this from your point of view, or is there flexibility if you had a different person reading that and say, no, keep the money? Is it pretty much a hard and fast statutory interpretation?
Mr. Chair, this is not Dan Pollack's choice. This is CMS, federal government. If we are allowed to treat it as a public grant or not for purposes of the applicable credit law. And by the way, I mean, if CMS tells us, no, you're not supposed to take that money back, it's still a cost. It just shows up in the forecast instead of on a fiscal note. So it's just it's an important detail.
We're concerned about the rate effect and how it would, and if it's been forgiven. Oh, are you there?
I'm sorry, Mr. Chair. I didn't hear your question. If you could restate.
I might have frozen up. So did CMS agree that it's a public grant? and they agree with the department's use, applying that statute and kind of recouping it.
Mr. Chair, as of 4 p.m. yesterday, CMS has not responded to our question, to specifically that question.
So it's still somewhat open. Okay. Well, let's take some testimony. Ms. Barnes, can you tell us a short story? Maybe a little less time than what you were counting on. Welcome to the committee.
Thank you. Thank you, Mr. Chair and committee members. Yeah, so much has been said that I totally agree with, and I'm here cheering the AL administrator for her comments and for yours and for everyone's. I've been in this for 40 years. I am the administrator at Lakeview Methodist in Fairmont. We've never felt this much pressure or this much gripping fear and anger about our situations. I just want to add a few things, if I could, just to the discussion before about staffing. I want to just make sure you all know that nursing homes have just not been sitting on our laurels and expecting all of the help to come from outside. Our nursing home, for instance, has a child daycare on our campus so that we can attract staff that way. We have a collaborative with the STEP program, supportive training and employment program. So we have 8 employees from that program here actually with their coaches. We take advantage of the scholarship program that the legislature put into effect to over $100,000 a year. So we are not sitting here and just asking for outside help. We have all tried everything we can to attract staff. But here in southern Minnesota, from 2000 to 2010, we had 514 new workers enter the area every year. Today, that number is a negative 21. So that's kind of obviously the base of our problem. Our financial footing has been severely fractured, not only because of the hundreds of thousands of dollars of extra COVID expenses, but because of 2 years of historically low census based on COVID. From 19 to 20, our revenue dropped by $874,000. We've always had a 21-month delay in reimbursement of our costs, and we're asking that you look at that too. But DHS now set to decrease our future revenue by offsetting our rates because of the PPP money. For us, would be on an average rate, $330 a day would be the normal rate we would expect next year. That would be cut back to $305. So just in that coming revenue for this year is $620,000 that would be cut from our budget. Every battle is insurmountable by itself, but together, this is just boding nursing home collapse. The staffing issue, the vaccine mandate, DHS wanting to eliminate the offset of COVID funds that we received, the 21-month delay. We are asking for your help in all of these areas, because although we have done as much as we can individually as nursing homes, we can't do any more, and we certainly can't do it alone. And as we look at the future, I'm looking at just our area. We have our 55 to 64 population has grown from 18,000 to 30,000. Our 65 to 74 from 15,000 to 23,000. So we are the only nursing home in this city of 10,000. So all of these things are meshing together to bode collapse if some of these things aren't taken care of. And we ask you especially to step in and stop DHS from taking back that money. Thank you.
Thank you, yeah. And so there is, I think, some time for the other two testifiers, Ms. Shuttle and Mr. Berner, if you could take a minute or two. And I hate to limit you, but just, give us add on to what's been said. And
yes.
I guess both on this topic and the other topics we're discussing, I'll give you a little liberty. So welcome to the committee, Ms. Shuttle.
Thank you. Good morning, Mr. Chair and committee members. For the record, my name is Sue Shuttle, and I'm the CEO of ARM. We are a statewide trade association dedicated to leading the advancements of home and community-based services for people with disabilities. I will focus my testimony on the workforce crisis, and Alan Berner will kind of close up our testimony.
Well, let's hold on workforce for a minute. We're on this $100 million thing. Maybe you just maybe I got I may have mixed up my list of testifiers.
Yeah.
So we're going to go to workforce in a little bit. So, and Mr. Berner, you're doing workforce too. Yeah. If that's
that is correct. Yeah, that's
okay. We'll just let's yeah, I just got this. Okay, that's fine. Let's hold on that. So let's talk about the 100 million. There is a draft language in there in your packet. That's again, I'm accepting the responsibility of this being my proposal, but the reason, I mean, 100 million, Senator Benson, $100 million is a lot of money. I totally understand. But I think it's 100 million, and nominally the numbers are in the range of 100. I just, that's a round number that makes sense. But it's not like it's a new $100 million. It's $100 million we thought they got to keep. At least if you would have asked me or other people, do you think they get to keep the payroll protection money just to have it for whatever and not mess up their rates for 22? I would have said, well, of course. And so either way, it comes out of the forecast or it comes out in the checkbook. So that's my defense of it. But I think it makes a lot of sense. I don't think anybody intended this money not to go their way. Senator Benson, oh, there you go. I see your hand.
Mr. Chair, thank you. Yes, it's a lot of money, but we did get some federal funds that could be diverted from other sources to help out nursing homes. I want to make sure that we're going to wait until we get a definitive answer from CMS. So I'm not trying to pull back on nursing homes, but I think I understood Mr. Pollack when he said CMS requires us to include these funds because we're a cost-based state. And so I guess the question is, has any other state that has our reimbursement structure been able to find a way to let the PPP funds not be counted against the nursing homes? I really want us to get clear on that. I'm not saying no to your proposal, Senator Abler. I just want us to make sure that we're checking every box. So we'll need a guidance letter from CMS at some point, I'm sure.
Yeah, I totally agree with you. Senator, so Mr. Pollack.
Mr. Chair, I'm going to have to follow up with Senator Benson on that. I don't know the answer, but it's a good question.
Okay, thank you.
So Senator Wickland, did you want to sign the check with me? Senator Wickland.
No, I don't have that available, but I guess my question's about your proposal. I mean, assuming that, that we find out the information from CMS, setting that aside, I guess my question about your specific proposal, and it's not so much about the dollar amount, but how do you think that this proposal would ensure that the money is going to the facilities that really are most needy? I guess, and how do you also see us ensuring that it's going to assist in supporting wages and the people that, it's critical that we find ways to enhance that. So I guess those are questions for you, since you developed the proposal. How do you think that we can make sure that we're addressing the right places that need it, and then whether the amounts are going to go towards broadly helping the facilities with the things to retain people?
It's a really good question. I think at the heart of it, it's going to rely on the integrity of the federal PPP program, where that money was derived based upon, I think, 3.5 months of wages, if I recollect, something like that. And then they were allowed to use it on a list of allowable costs. And so I believe these facilities got the money thinking they were getting to keep it. Only matters to nursing homes because none of the rest of them are cost-based. So assisted livings that got the money, or the Chevy dealer down the road, they got to keep the money to do whatever they did with it based upon allowable uses. So I'm confident that they will certainly follow the federal guidelines on that. This is just saying we're not going to take it away from you now that you've spent it on your payroll and so on. And I'll just go a bit further. As you dig into this, and I know you will, there are a lot of methods to get this money back in the hands of the nursing homes that are losing this money. This is the simplest, cleanest way, especially for a hearing like this, to come forward with a proposal to say, let's restore the money. And one way or the other, we're going to wind up paying for it. There are ways that involve sharing federal match with it as a rate increase, a temporary rate increase for certain ones. I think that's maybe a little more problematic because now who gets what. And this is meant to be targeted to the places that got the money, keep the money. And Senator Benson and Senator Wickman both. It's not my imagination that this would be a special session topic unless there suddenly was an appreciation for what a great idea it is and how we need to do it now to adjust the rates. And I'm all in for that. But I don't want to confound what is already a pretty choppy road to a special session. But I'm eager that there could be one to solve hero pay that came up, as well as some other things. But that's my best thought. So again, the committee in the Senate that's charged with dealing with this matter is first ones it's coming up to and for your scrutiny. And I'm eager as anybody else to hear from Mr. Pollack and what CMS is going to respond to. So Senator Wickman.
Yeah, it just sounds like, we'll have more discussion about it. And if we have more discussion about this particular proposal, we can maybe get more data on, how you think it fulfills distribution to the right people. And I understand that those who applied for the PPP money, they may have had some assumptions. I'm just trying to figure out what the best use of state, what the resources we have, whether they're state or federal, is the best way to get money out there to everyone. So
good point. Anybody else on this topic? You get the last word if you want it. Mr. Pollack, you know enough to be dangerous. Anything else you want to tell us? No.
Oh, there's Senator Hoffman has a hand up.
Oh, he does. Senator Hoffman, thanks for.
Senator Abler, thank you. And I sent Assistant Commissioner Pollack the note that you and I were CC'd on regarding the other system that we're talking about in here as well. So I look forward to the discussion following this, Senator Abler, because and Senator Wickland brings it up. What is the proper use? How do we use it? Where should we use it? Right? There's money that needs to be spent. How do we fix and protect our systems that are out there protecting our most vulnerable? So I look forward to that.
Well, super. So with that, we'll put this topic aside as further work. Just to announce to folks, I think we'll touch on every topic, but I think the Subminimum Wage Task Force will be very brief. The PCA situation will be brief. And then we're going to put our time into workforce mostly, and then I think the department has an update on fingerprinting. So let's move to workforce. Now, Ms. Shuttle, welcome back to the committee. I
Thank you.
got you in the right topic area here now.
That's all right.
Workforce.
Thank you very
You know
much.
something about workforce?
Yeah,
Okay,
I
go ahead.
do actually. Again, for the record, my name is Sue Shuttle. I'm the CEO of ARM. I've been at ARM for 4 years, and I can tell you that from the minute I walked in the door at the association, we talked about workforce and just that it's a problem consistently. But I can tell you that things are different now, and there are many providers that are really afraid and are really struggling with supporting the people that they need to support in group home settings and ICFs, et cetera. So I'm here today to echo what all the other testifiers have said, that things are really rough out there. Statewide, the picture is very scary. Providers report vacancy rates exceeding 30%, with staff leaving almost as quickly as they get hired. Our providers report a turnover rate of nearly 50% of staff who leave within the first year. This instability among new staff has a trickle-down effect with long-term staff. We're seeing an increase in the burnout of direct support professionals that have been there for a long time, as well as supervisors that are constantly asked to do more and to cover more shifts. As providers search to find creative ways to bring in new staff, they're being presented with various challenges and hurdles. One of those come in the form of background studies. Senator Abler, you referenced that we'll be talking about that. Recently, the state returned to the full background studies, which now includes fingerprinting. Additionally, the state has contracted with a new vendor to process these background studies. With the new vendor, the ability of providers to purchase their own equipment is limited, and locations are not yet widespread. One of our outstate members recently shared with me that the nearest location for her staff to get fingerprinted was a 45-minute drive. 45 miles away. Asking a potential DSP who's making $13 an hour to drive 90 miles round trip isn't a great way to retain a staff member, a potential staff member. Additionally, providers have shared that background checks can take weeks to get back. We know that this is a barrier that is obviously a problem as well. So what does all this mean for the people that we are providing support to? The inability to safely care and support individuals due to the workforce crisis has forced many providers to make challenging decisions. Providers are closing homes and reducing the number of people that they provide services to. Many of these changes fall heavily on individuals with high medical support needs. And as providers just simply can't find the staff to support those people with high needs. For the people that depend on home and community-based services to live and work where they choose, they will experience life-altering changes if we can't find more staff to support them. We often hear about the restaurant industry and all of the shortages that they're having. We're talking about real people here in their lives, and we're just really trying to elevate that conversation with you today. We need to act now. We simply can't afford to take major steps in addressing the workforce crisis that exists currently. I want to thank the chair for holding this hearing and his ongoing commitment to people with disabilities. We know that this is a complicated problem that will require many solutions in order to make meaningful change, and we're eager to work together to find those solutions. I'm going to kick it over to Alan Berner, who's one of our members. He's the Vice President of Community Services at the Phoenix Residence. Alan will speak directly to the impact of the workforce crisis that he's experiencing at his location.
Mr. Berner, welcome to the committee.
Thank you, Mr. Chair and committee members. As Sue said, my name is Alan Berner. I work for an organization called the Phoenix Residence. I support adults with disabilities in 20 homes. I've done so here for a little over 15 years, and I appreciate the opportunity to talk and share our experience here at Phoenix. To be frank, we've moved from a shortage to a crisis. Our staffing continues, like we've recognized here by past speakers, to be exceptionally unstable. Requires all of what we have to simply problem solve, getting people into shifts and be able to take care of the immediate needs of people in our homes. As we work through the protocols at the same time and exclude a number of the staff we have as lead symptom screen and do close contact monitoring with folks. We've used our staff, for everything they can, stretching beyond kind of what their intended work hours and needs are to help make sure that everything is covered. In order to kind of piece all this together, our leadership team devotes a significant amount of time just problem solving the day-to-day staffing shortages, recruiting staff to cover shifts, trying to figure those things out. And too often our staff aren't able to even meet those gaps. And so our leadership team jumps into cover, everybody from our frontline managers to our CEO. This past weekend, we had 6 to 7 of our leadership and executive team working the floor just to cover openings that came up as we went through. And the personal cost of navigating through this is evident in all of our staff. Our employees and their families have sacrificed so much just to try and get through, and we're beginning to see a lot of our better staff members resign and move on. citing they're no longer able to meet the needs of the people we support and still be the person that their families and others, need them to be. Many haven't had time for their kids. They haven't taken vacations. They've worked as long and hard as they can. And a lot of them have answered our calls for help over and over again. So a lot of times at a moment's notice. Personally, this is something that's that's been hard for all of us. But just to put a personal perspective on it, I personally have 3 boys. My wife took off work this last year as we anticipated kind of what was to come as we waited into the pandemic and not knowing what school was going to look like. And in the past year, I've spent a month away from my family as we went through a COVID outbreak in January. Stayed in hotels multiple times because my ability to commute home, the amount of time it takes me to do that. I live 30 minutes away from some of our places, but the amount of time to drive home just to get a few hours of sleep, was prohibitive. For 3 months this summer, I went from working as our executive vice president here, to doing about 6 out of 7 days a week on overnights. We didn't have other people available. And so the cost of that really lays on the feet of my wife and parenting our kids and keeping everything going there in running our household. She's since returned to work, but the pandemic and the shortage and the work pace that we have hasn't changed. And the toll it's taken here with our mid-level folks and our, my director staff. I have 5 mid-level directors in the organization. 3 of them have resigned in the last month. And we've all been kind of holding out that, in the fall, we'd start to see things start to shift, that we'd see applications increase. We'd start to figure out how our direct care staff and be able to stabilize some of this. And the 3 of them have, all cited, the passion and investment they have in the work that we do hasn't changed. They love what we do. They love the organization, people we do it for, but what it takes is too much. They aren't able to keep doing this. They can't work the way that unfortunately we need to in order to keep people there, and the cost of that and what it means for our organization. It is great. Losing those veteran leaders and those people that know our organization so well will continue to impact us, in the months and years to come. In the face of this, we decided to close one of our programs, and knowing that we have some individuals there that are going to have a hard time finding services elsewhere. But unfortunately, the resources for us to keep doing it in a safe manner don't exist. We know that Phoenix isn't the only location that's needed to close programs. We've had an influx of referrals for the open beds that we do have in other locations, and some of them citing that they've been given notice of the closure of their current home with less than a week to find a new place to move. Others have had similar experiences, but the 1 week notice was the most extreme. But we've had others reach out and say that their programs are closing and they need to find a new place to go. We have some single opening vacancies throughout our organization. We've been working to try and find places for them where our staffing is relatively intact. I would implore this committee to consider significant decisive action to help stabilize our services that are essential to the livelihood of some of Minnesota's most vulnerable citizens. I think we've spoken eloquently in years past about how to fulfill the promise to take care of them, meet the needs, and frankly, we are failing. As we see more providers close the doors, individuals they serve need somewhere to go, and planful action is going to be necessary to take care of these individuals and find a way to find a home or a space within our healthcare system that's already burdened, as we've heard from other long-term care space, and we know our hospitals are equally stressed at this point in time. I understand we're not the only ones expressing the challenges we're facing with the workforce, but the work we do can't be left undone. I'm not only talking about the quality of life for the people we support, but we are moving into health and safety of the people and the risks are very real to a lot of the people we support, that without some quick and planful measures, that we will have negative outcomes for some of the people that are supported by a number of providers. I, along with so many of us, have poured our lives and our hearts into this work to do the best for the people that trust us and rely on us. But even for our most committed, this is unsustainable. We can't ask this of individual people to continue to do it the way it's being done. And without something quick and impactful, I expect that we will continue to see our challenges increase. And this, as I kind of consider my comments here and then listen more, the vaccine mandate, only makes this all the more critical for us at this time.
Well, thanks. And you've been very eloquent, both of you have. Mr. Berner, though, the vaccine mandate doesn't apply to you unless you're a state, like an MSOX facility, or unless you're over 100 people in your organization. And so is your organization more than 100 people? And is that how that runs?
Our organization is over 100 people. So we serve 100 individuals, currently have probably about 160 staff members. And we do operate ICF-DD facilities, which are overseen directly by the Department of Health. And so as we understand it right now, we will be included in the expectation for the vaccine mandate.
So I'm and that's helpful. And we've had some meetings offline, didn't include you, but you're just very eloquent, and Ms. Shuttle as well. If you take away all the vaccine stuff, you're still on the verge of it not working. And
correct.
So in the meeting, I suggested, not glibly, that it would be productive. I think to get people somehow caring about this is the trickiest part. I don't know what our viewership is today. This should be headline news on the 12 o'clock news. The first part about nursing homes and second part about you all. And I don't know how the coverage will be, but it seems to me that if there was a way to communicate with all of your clients' families and say, by the way, we're on a pretty short leash here, and we're like 2 people away from not even serving your family. So be ready on a short notice to come have them live with you again. And, to the state, you'd send a letter to the good commissioner and say, hey, by the way, those guardians you got, you might be seeing them again sooner than you think. And I'm not being facetious, but I don't know how you call attention to this. This committee is as versed as any group in the state about this, and it still just grieves me as I hear, and it gets a whole new level of understanding. And we're the ones in the know. So anyway, comments from members? And I admire your workers, Mr. Berner. The people that I've met over 2 decades doing this, they're just so committed to the people they're become part of the family. And all they want to do is be able to afford to work there. They'd like to actually have enough money to buy bread and pay their rent, and they're just so amazing. Anyway. Ms. Shuttle.
Yeah, I just want to close my comments here just to say that as I started off, when I started at ARM, things were bad. But I heard we had a meeting last week with, I think there were 6 provider organizations that were there, and every single one of them, including very large organizations and smaller organizations, are saying they're on the brink. So this is, I'm preaching to the choir here because I know you've heard it before from us, but we're wanting to put folks on notice that this is real. This is real, it's happening, and providers are going to be closing programs, as Alan talked about. So, all
right. Well, the purpose of this component compared to the first hour we spent on nursing homes, where it was just, we were trying to find some idea of a solution, or at least, I want to at least give you the chance to hear, or let the public hear what's going on. And there's a lot of parallels. So thank you for that. We'll put this aside. Senator Utke, can you give us a 2-minute update on the Subminimum Wage Task Force, and then as a draft, and just if you can be kind of thematic? Because as we talked, I'm gonna send you off and have more work. So,
Okay.
Senator Utke.
Thank you, Mr. Chair. I want to make sure my audio is working. Can you hear me?
Yep.
Okay, good. Because my webcam crashed and I'm using the secondary system. But anyhow, just the quick update is everybody got a copy of the draft amendment. And basically what that was is rather than everything stating the elimination of the subminimum wage, we've changed it to promote independence and increase opportunities for people with disabilities to earn competitive wages. And with that, we also added the 4 more seats to the task force, and we spelled out who those 4 seats would represent or who would fill them. And one last thing on the amendment itself, at this point, we have not put in effective dates, a little bit of the technical part of it. And that's because, of course, we don't know if we would be having a special session where what we're working on would be brought forward, or if it's going to be when we get back to regular session. So that little piece we've just left alone because there's no use putting something in that we don't know what that part of it is. There were 3 letters that were submitted under this section. I want to just highlight a couple sentences and such. The letters were from Legal Aid, the ARC, and Autism Society of Minnesota. A couple things that jumped out on me. They come out negative against what the amendment says as far as softening this. They want to stay with the elimination. They have one of the highlights I put, plan to phase out the use of subminimum wage for people who have disabilities so that all people with disabilities who work will be paid fair wages. My comment there, we have 7,000 Minnesotans who work under the 14C licensure or the subminimum wage. If this is eliminated, their job is eliminated. We are trying to maintain what that small number of people, it's 7,000, but it's a very important 7,000, maintaining their livelihood. And their livelihood is more their enjoyment for doing the job that they are doing, showing up daily with their friends. The alternative is, we've mentioned before, is probably an adult daycare. And again, with those 3 letters, my challenge to you is, the letter writers, is please contact us. Let's work through this. We can come up with a solution, but the solution isn't just flat eliminating these subminimum wages, because we've got important people around the state that depend on these. We'll do everything we can to help people move out of that if it's possible, but we know that in reality, that's where some of the people are going to be. And we want them to maintain their job. We want to help them maintain it. We want them to be happy, just like we get to do what we want to do. And so with that, I would just ask, if you've got concerns about the amendment as it sits, please contact us so that when the opportunity comes that we can present this, whether it's special session or regular session, we can move forward with something that's agreeable to all and is workable. So with that, Mr. Chair, thank you.
I think that's well said. And I hope that people understand the tone of Senator Utke and also Senator Hoffman, who's been working on this. And if you've been around or any like the time, task forces come and task forces go. And the average task force winds up being a very nice way to spend some time, get to know somebody, and then oftentimes very little happens as a result of that task force, particularly if it's gone too far one way or the other. And so I'm concerned that if the task force goes forward the way it is, when the conclusions that come out, particularly if it's skewed toward elimination, that there's going to be huge pushback on that, and I'll probably help. And so the the recommendations won't be treated as well. And so I do believe that, I mean, to change a law, you have to get a consensus on both sides and the administration. I believe there's a path to that. And I think the real best work done in this topic area is to have a broad-based consideration of what's the best for every individual, and how are we going to handle it if the feds say it has to go away, which you know, they say things sometimes. So we want to be at least ready for the discussion. But I just can't imagine what's going to happen to some of those individuals, where they would go, short of just sitting home. So anyway, so that's my desire. So let's kind of all pull together. The three writers, I'm grateful for what you wrote. I totally get it. I count myself your friend. But work with Senator Uckey and Senator Hoffman and see if we can't find a way to make this an even more productive task force that people will want to listen to the result of. So Senator Uckey, you did great there. The next, we're not doing too bad, but so we're just going to keep moving here. Ms. Mertz has the update on CFFS about the delays. But what provoked this was a discussion about allowing PCAs to drive their clients, which we thought was great. We tied it to CFFS with an effective date of October, I think, in federal approval. And that's delayed now, so we don't have anything. And so the draft you have in front of you talks about adding PCAs in to that. If I were the king, I would love to get this done for a special session. It might cost some money, but I just think that, especially given staffing, as we talked about, if for heaven's sakes, a person sitting there with their PCA, they have a car, could you go buy the guy some socks or buy the woman some groceries for her place? Anyway, so that's the goal here. I think it's pretty much a white hat topic. It passed last year pretty much without objection. Anyway, as I recall. So Ms. Mertz, do you want to give us the update on CFS as a whole, please? Are you there? There you are. I see you. Seems like you're muted for some reason. That just seems wrong. Mr. Brennan, you got an idea?
I do not, sir. Maybe just log out quick and try logging back in. I can look for you on the participant bar.
Let's just jump ahead then to the background study. So I think we have to be brief on this. So for sure, Ms. Moti, if you can tell us the changes, and I think perhaps Ms. Krinke could take on the task of speaking on behalf of the industry. Ms. Moti, are you there to talk about there's been some changes I just heard about today, which I think people will be happy about.
I guess I'm here. Are you able to hear me, Chair Abler?
You win. You win the contest for your department. Who didn't get to be not heard first? There you go. Okay.
Thank you, Mr. Chair and Senators. My name is Kulani Moti, and I serve as the Inspector General here at DHS. And so I wanted to just give a brief update on where we're at with background studies and our transition. So just to let everyone know that we started the transition from emergency studies to full fingerprint-based background studies in phases by provider type on September 15th for new background checks. We started with DHS and DOC child focus programs. And then more recently, I've brought on the rest of DHS regulated programs, which would be for licensed providers and non-licensed providers. The next group that we had scheduled in our phasing in was to make the transition for MDH regulated providers, which would include hospitals, long-term care, and assisted living facilities. And as throughout our entire process of putting together this plan, we had built in and opportunities to review and update as our situation evolves on this, taking a look at capacities and where we're at and what's going on. And so at this time, we are going to delay transitioning back the MDH regulated providers to Wednesday, January 5th, 2022. And we're doing that for a couple of reasons. Currently, our fingerprint vendor has about 74 locations across the state, which is about just under what we had pre-switching with the vendor, which was about between 80 to 83. This will allow us time to continue to bring on above and beyond that 80-83 that we had previously, as well as to allow entities that are eligible to purchase their own devices to go through that process, and if they're able to complete that process on that. And with that, we've also looked at adjusting our transition timeline for those emergency studies. And so we're adjusting that timeline and continuing to use the phased-in approach. So on December 1st, we would start with that child care focused group of providers for DHS and DOC providers. And that would go, and we'd really focus on asking those program areas to submit those resubmissions of any emergency background studies, and that would be looking from December 1st through January 31st. Then focusing in on DHS regulated entities, so the licensed and non-licensed providers starting in February through the end of March, and then really working with MDH to push through their resubmissions starting in April on that. So wanted to be able to give that update to the committee members today as we continue to monitor and adjust as needed and accordingly our transition timeline.
Well, thanks, Ms. Modi, and I appreciate what I hear in that as some responsiveness to the concerns of the community. Ms. Krinke, did you want to comment?
Yes. Thank you, Mr. Chair and members of the committee. For the record, my name is Mary Krinke, and I'm with the Minnesota Hospital Association. And I want to start by echoing something that Assistant Commissioner Pollack said, the importance of these public Senator Benson had a hearing a couple weeks ago in which we did talk about the fingerprinting challenges that we had. And you're hearing again today, Senator Abler. I think this is helping to bring our concerns to the public. And I do want to thank DHS for responding to some of the issues that we have brought forward. This additional time giving us till January 5th. Hopefully, and I knock on wood here, hopefully the COVID numbers will subside a little bit by then. We had a big increase over the weekend, and we are very, very busy with COVID right now. So getting some relief on this fingerprinting is going to be very helpful for us. So thank you to the department for delaying the start until January 5th for the hospitals. Also, I think the phased-in approach of the backlog, getting through some of the backlog here and doing it with some phase in will also be helpful, that we don't rush the public sites all at once. And so we still have concerns about being able to purchase the equipment, and we're working with the department and the vendor to try to make that easier to purchase the equipment. And we also are working with the department on another bill that we introduced last legislative session regarding eliminating some of the duplicate procedures between the licensing boards and DHS for those healthcare professionals that are licensed separately by their healthcare professions, Board of Nursing, Board of Medical Practices. Is this second background check and fingerprinting process with DHS necessary for that group of individuals? So we continue to work on that, but very pleased with what was announced today. So deep appreciation and thank you.
Oh, yeah, thank you. Senator Benson, did you want to say something?
Mr. Chair, I just wanted to note that there are entities purchasing this equipment, and part of the reason that DHS is moving the background timeline for MDH regulated facilities is because they're waiting for this equipment to go through the paperwork process and come online, so that we will have more capacity. The vendor is trying to roll out sites. I understand that they're not all rolled out and not all in the locations that might be most convenient, but they are being flexible and responsive in the hopes that we get all of these background checks taken care of by July 2nd, July 1st of next year. And so for those, and for smaller entities, that frees up capacity. You know, maybe the vendor can have a special sprint appointment time to make sure that people get guaranteed access. I think DHS has done a really good job, and Ms. Moti trying to make this work with a new vendor coming online is, I think, doing everything she can to be flexible. But let's keep an eye on this, and if we could do mobile unit for these vendors so that it's more convenient for people who would have to drive 45 miles, let's put that on the list of things that might be something worth working on. So,
Mr. Chairman, if I may, one last thing I've heard from a number of our members that might be helpful is if on the website it could say what the capacity is, or estimated capacity. Is it a site that can do 100 a day, or is it a site that can do 10 a day? And that would help as individuals are trying to schedule their fingerprinting appointments. So just one other issue that I've heard numerous times. So
yeah, thank you. And so to the committee, I just talked to the commissioner this morning and got this heads up. And the question I did ask is like, who set the deadline? That would be us. The department and the legislature together agreed on the deadline. So that is a Minnesota deadline that could be softened. Ms. Cunningham, if you want to take 30 seconds, I can give you that, then we got to move along. So
okay, 30 seconds. City Cunningham, family child care provider in St. Paul, public policy chair. Again, the location, the hours, those things are critical, but also what has become critical for family child care providers in particular is that when this was being rolled out, for us to all get up to speed on this, there was a cost coverage guaranteed by the state for anyone who had previously had a background check in our families, spouse, children, helpers, substitutes, and the provider. And as this is being re-rolled out, we've all been notified that it will only be in as money is available, and the money is going to run out. We don't need one more stress. We don't need one more pressure. We have no control over when the counties are rolling it out or in what order. Some providers have up to 5 people, and the legislature raised the adolescent coverage rate. So now that is even a bigger impact for providers. So that needs covered, that needs honored.
Yeah, thank you. Mr. Burdick, can you put a pin in that and get back to me about this one? So thank you. And so I don't think we're all the way there. We didn't line up a whole crew of people from all the other groups. Just if you're having trouble with the background fingerprint stuff, please let me know. It really will matter. And I just want to thank the people that said thanks for having hearings. Sometimes I just think we're annoying to people, but I think that these programs are best aired. And so this is frankly the 5th hearing that this committee has been a part of, and I want to thank them for their hard work. Ms. Mertz, are you back? Did you get your voice thing working?
Mr. Chair, can you hear me?
There you go. Yeah, perfect.
Hey.
Yeah, so tell us about CFFS and bring it home. Thank you.
Surely, thank you. Mr. Chair, members of the committee, my name is Natasha Mers. I'm the Director of the Disability Services Division at the Department of Human Services. I'm here today to provide an update on a delay in the implementation of Community First Services and Supports. We had hoped to implement this program on January 1 of 22, and that is going to be delayed at least until the summer of 22. Meanwhile, the existing PCA program remains operational and functional, and so people will continue to have access to the same services and supports that they've had in the past. But the delay is attributable to the complexity of getting the federal approvals to cover all of the different populations of people that we need to maintain or create eligibility for CFFS that are currently eligible for the PCA program. So I can go into a little more detail on that if that's of interest to the committee, but I know we are at time, Mr. Chair, so I'll pause there and see if there's specific issues you'd like me to address.
Can you explain like where the delay, why is it delayed? We were also optimistic, you know? The summer's we were very tomorrow, you know, remember Annie. And so anyway, it's only a day away. Okay.
Mr. Chair, yes, we were optimistic and we are disappointed about the ongoing delay to implement these really important program changes that are allowed in CFFS that aren't currently allowed in our PCA program, like purchasing goods and services as a replacement for human assistance and a pure self-directed model of services and supports. So the basis for the delay is we need federal authority to make this transition, and we need at least 5 different lines of federal authority in order to implement the change and make sure people that are currently eligible for PCA remain eligible for CFFS. So we didn't anticipate the level of sort of questions and details that we would have from CMS on how these different federal authorities work together. So we need a package of amendments that includes I'm just going to rattle off numbers: 1915I, 1915K, 1915C, and then a couple other ones. So we have to submit separate amendment packages for each of those authorities and work with CMS to help them understand how the entire amendment package supports the transition from an already very large PCA program into a just as large CFFS program.
All right. And so, when there was quite strong agreement about this transportation bit that a PCA could drive them around. And I didn't ask them, I hate to put you on the spot, although I do it all the time, but it may cost some money, but is that something that you guys would be friendly to trying to move up and just stick back in the PCA program? And what is that? Let's say we passed a law today that PCA can do it. There'll be a several month approval process with the feds about that, right?
Correct. That would require a state plan amendment to our current authority. And, certainly we've worked with stakeholders over the years on the PCA transportation issue and are happy to be partners in that, in administering or implementing that if we're given direction by the legislature.
So let's say everybody loves it. We pass it today. What's the fastest possible track? Just, you start scribbling stuff down on paper and mail it in. Is that 4 months? Is that the quickest it could be?
That would be a very, very optimistic timeline. And Senator Abler, I am sensitive to people's understandable skepticism about the ability to implement CFFS on appropriate
It wasn't even a trick question. So I mean, so if we get past it today, it's still going to be 6 months. And if CFFS, so is it? We'll talk offline if it's even worth trying. Yeah. I'm just disappointed we didn't try earlier, and I was part of that decision, and so I'm sorry to the people. What if they just did it? What if a person just drove people to the store and bought them socks and didn't clock out? What would happen? They'd probably be in prison. So, why are you in prison? Oh, I bought socks.
Senator Abler, it is not a covered service under medical assistance. So if a PCA were to, transport a person to the store to buy socks or do whatever, the provider agency can't bill medical assistance and be reimbursed for the cost of the time of that service, but the worker would be entitled to be paid wages and compensation for that.
And so do you care? I mean, I didn't mean to get into this, but so do we care if a person is taking care of a person while they're sitting in so they could sit in their car and listen to the radio? That'd be allowable time to be spent. But they turn the key and drive somewhere. Is there something unique about the moment that they're on the highway that makes that time not compensable? It just seems funny to me. They're both sitting there anyway.
Yeah. Mr. Chair, yeah, we've heard that from multiple stakeholders where the policy on covered transportation is complicated, and I think that's the real basis for for stakeholders wanting to bring forward and make a change and make it really clear so that a provider could legitimately bill medical assistance or Medicaid for driving someone somewhere, whereas they can currently do it for just accompanying them.
Yeah, so if they I don't know. So I'm going to quit pretty soon, I promise. But so let's say they don't care if they get paid for any mileage or driving unique tasks related to steering. But so the minute they turn the key and they're on the highway, that time that they're with their PCA is not compensable by the feds or us. that right?
Correct.
Wow. You know, hey, you know, there's a COVID crisis on. Have you heard? You know, there's people that can't find any PCAs. Never mind. So you were here for the first part of the meeting. It just seems so amazing in the first hour of this meeting about the crisis, and the middle part talking about the staffing and group homes. We are certainly a very developed country. Ms. Mertz, you're just the messenger. Thank you for that. And we'll, I think I still might try to pursue it just because. So your best date on CFFS is now July 1, or is that soft?
I would say that that is soft. That's certainly the date we're targeting, but we need to be able to submit amendment packages and then have CMS approve amendments within 90 days. And that also includes public comment period of time. And so at any given time, CMS can do what's called pull us off the clock and request more information, which could potentially delay our ability to get approval, which is necessary to implement.
When you took this job, you probably thought, I get to help people. And did you have any idea of the level of complexity? That's just, never mind. Well, I think this has been a very good hearing, everybody. I just have one more thing to mention. I'm going to mention that we're very likely to be meeting on December 8th, talking about what's ever happened at nursing homes as a result of the first deadline. We'll shop this payroll protection matter around some more. There may be a resolution of the subminimum wage by then. Maybe the special session will be scheduled. I just want to blame whoever encouraged me for having public hearings for my last announcement here. We had, in 3 of our meetings, we talked about the state testing thing with that. And I've been concerned not about the testing, but about equitable treatment to the state employees, which we have not achieved. And I just got an email last night, and it just, I don't know, I'm just going to read it, and then you can, at least these people that wrote will feel like they had their moment, because no one's listening to them about unfair treatment. DOC is placing all positives on FMLA, regardless of whether the staff wants FMLA. To top that, this scenario also happened. Husband-wife team work for DOC. Wife tested positive, but is vaccinated, so she gets to return to work in 10 days. Husband is unvaccinated, but has tested negative twice, but DOC demands he stays out of work for 14 days. HR said this was policy, but nobody can produce a written policy that states that. And we still have the policy in place that says if you get COVID as a vaccinated state employee, which at one point wasn't supposed to happen, but anyway, so if you get COVID, you get 7 days of paid time off. If you get COVID as an unvaccinated person, you get no paid time off. You don't get your 7 days that they get. And I don't know, I just don't see, in a world we're trying to get good employees, you know, I hope you see where I've steered this discussion away from all the controversy part, but we got to treat people fair. The whole essence of this committee is treating people well that have a disability or some challenge they need help with, economic supports and all. And our state employees are so dedicated and they are so good to have. We need every one of them. And we need every nursing home worker. We need every group home worker. Anyway, I want to thank everybody for their attention. And to those who want to have more hearings, there'll be one in a month. In the meantime, happy Thanksgiving and God bless us, everyone. Thank you.